Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Lunch with the Investigators. This is a day we're going to focus on the management of gastroesophageal cancers. We have a great faculty, Dr. Yelena Y Janjigian from Memorial Sloan Kettering, Dr. Manish Shah from the Weill Cornell Medical Center, and Dr. Harry Yoon from the Mayo Clinic in Rochester. We're really looking forward to this program. This is the first of 9 programs we're doing here in this room over the next few days, and I'm proud to say that only one of these programs have we ever tried with the format that we're using, and it's not this one, because we are trying something different today. So these are the 7 topics that we put out to these 75 oncologists and asked them for each topic. First of all, we asked them, how important is that topic to you? Do you want to learn more about it, and how does it compare to the other topics? But then we asked them, tell us about cases, tell us about questions. We're going to try to get through some of those today, but there are many more that you may want to look through. This incidentally, when we asked them to rate number 1 and number 2 choices of what they would like to see us cover, interestingly, and this may reflect what's going on in general medical oncology, which is really the rapid utilization of tumor-informed cell-free DNA, mainly in colon cancer, but people are asking about it and doing about it. You're going to hear about it this whole weekend, and interestingly, very high level of interest, but also immunotherapy. We get so many questions about both adjuvant and metastatic disease. You can see that those are very highly rated. And of course, Zolbetuximab. The recent spotlight trials have gendered a lot of interest as well. These are some of the topics we're going to go through. So we're going to start out talking about localized upper GI cancers. And you can see when you look at these, so on the left is the docs this is out of 75 people. So people who feel well informed are more in the green shade. You're going to see some other questions where people, if you're very uninformed, you see a lot of red, and then a big bunch of people in the middle. But still, more than half of these people have significant questions about this topic. Here are some of the papers that we want to keep in mind. There are many more, including some, for example, the attraction study is going to be presented here at ASCO. But we're really here just to chat with the faculty today. We want to spend a lot of time going through the data. We want to just chat about what it means. But I just want to start out with a question that literally, again, we asked these docs to comment on 5 of the programs we're doing here, including tomorrow's program on hepatobiliary. And every single one, Yelena, we see questions because this is going on in the community about chemotherapy shortage. So I'm curious, we were chatting before about some of the conversations going on Twitter about that. There are people in the community setting who cannot access carboplatin, for example. Even tertiary centers, Sarah Cannon is having difficulty.
We got an email and notification from our center and pharmacy that carboplatin is in shortage. I think when it comes into play is not so much for metastatic disease, but early or locally advanced disease. 5FU has been okay. I mean, there's always these leucovorin shortages. I would not worry about the leucovorin shortage. In fact, even for protocol patients, I often drop leucovorin because I think it does add more toxicity, less efficacy. And then the patients get anxious because they feel like they're missing out on something, and I would reassure them they're not. For the carboplatin shortage, I think if you're used to using carboplatin paclitaxel in the clinic, it's an issue. The way that I would think about it is majority of our patients are adenocarcinomas, and there's plenty of data and expert opinions to suggest that, in fact, we should be pivoting from carboplatin paclitaxel for those patients and using 5FU oxaliplatin in combination with radiation. I know Manish has been saying that for a while, that 5FU is a better radiosensitizer, and now we have data for that. And so it really just squamous patients, right, that carbotaxel is more important for with radiation, and those are relatively rare.
Yeah. Manish, any thoughts?
Yeah, so And then for squamous cell cancer in particular, cisplatin actually could be substituted for carboplatin. There is standard phase 2 data that suggests that, carboplatin is really an important drug, and based on the cross regimen, is standard of care. But a low dose weekly cisplatin, is actually probably equally effective. The reason why people moved away from it is from a toxicity standpoint. But if you're able to reduce the dose and manage the toxicity, you could sort of get by. I mean, the bigger picture, and I think ASCO has guidelines, and they've actually, lobbying Congress as well about this, is that we need to sort of fix these issues with shortages. Like, these are drugs that people should have access to. But when there are shortages, I think carboplatin is probably, not the strongest drug. And from a platinum standpoint, both oxaliplatin and cisplatin are probably better in terms of anti-tumor efficacy. It's just the issue of managing toxicity, as Yelena said.
So let's get into the meat of what we're going to talk about. And Harry, we get lots of questions about the use of immunotherapy in the adjuvant setting. Can you kind of provide a basic overview and what you say to your fellows in terms of how you think through the issue of the use of immunotherapy in localized gastroesophageal cancer? How do you factor in location, histology, PD-1 levels?
So I think the use of immunotherapy in the curative intent setting for these cancers, the only data right now is after trimodality therapy is completed and there's residual tumor in the surgical specimen. So we know in that situation, we should definitely be thinking about immunotherapy, and the standard of care is adjuvant nivolumab for 1 year. And there's some exploratory data suggesting that maybe the CPS, PD-L1 CPS less than 5 maybe don't benefit so much, and the benefit is driven by the CPS greater than 5. But to me, that's an exploratory set of data that we haven't seen a whole lot yet in the locally advanced setting, although there's accumulating data in the stage 4 group. And then in terms of every other setting for immunotherapy and curative intent, it's all under investigation. And I think there's promising early data, but right now I would enroll those patients on clinical trials.
So, Yelena, another issue, and actually, I actually got an email about a case of this last night, is the issue of localized MSI-high upper GI cancers and the use of immunotherapy. Of course, your place put out the incredible paper initially using dostarlimab with the rectal cancer. Everybody responded. And we're seeing more data now using neoadjuvant IO, and particularly we saw neoadjuvant ipi-nivo. So I'm curious right now, if you have a patient with localized upper GI cancer, and you can talk about how, again, location, histology affects it, but they are MSI high, what are you doing outside of a trial?
Yeah, it's a great question, and in reality, we really don't know, and so the answer should be find a trial. I don't think doing FLOT is a good option, because that would be the standard option. I think taking them to surgery first, if R0 resection is feasible, is probably the textbook answer that we would do. What would I do if everything was perfect? And I would be very hesitant to do IO alone. Again, my experience with this disease, and what I can tell you from patient stories, the response is quite mixed and heterogeneous. It's not 100%. Remember, rectal tumors, at least in that cohort, many of them were Lynch tumors. Our disease is different. And even with longer course of immunotherapy, in combination dual PD-1 CTLA-4 blockade, I'm worried about non-operative approach. And so if you have access to Nivo, it'd be great. Maybe that's a better option, but still surgery. But I think probably the answer would be two-drug combination with immunotherapy such as FOLFOX-Nivo or Capox-Pembro. Again, no data. So by data, it would be surgery first.
Manish?
Yeah, I agree. I think that your study with FOLFOX-Nivo and the MSI-high population, I mean, the hazard ratio was like 0.35 or something like that. So really, in the MSI-high population, there's a really, really significant benefit of adding immunotherapy to chemotherapy for that population. And for the locally advanced patients, a lot of these patients have actually truly locally advanced tumors and they're borderline resectable. And so I've used that argument to give them FOLFOX/nivo, and I think so. One option is to try to do that if you can. If you can't, then surgery is the right thing. But I think Dr. Janjigian mentioned something very important, which is, will we get to a point where we have a clinical complete response, and should we then not operate on these patients? And that's to a certain extent being addressed with the rectal studies, but we don't really have the data in upper GI cancers on not operating with these patients, and I think that's something that needs to be developed. There is actually an intergroup study that is being developed to address that question.
So, Harry, a couple questions from the oncologist. I got through like 10 questions and I immediately knew what the most common one was, which is the patient who gets neoadjuvant chemoradiation and then doesn't go to surgery. We have one case here at the top, a 73-year-old man, not a surgical candidate. We don't know why. There's a past history of follicular lymphoma. But Harry, can you just sort of generically talk about the issue of how you think through the patient who gets chemoradiation therapy but then doesn't go to surgery? Either they decide they don't want to, or the doc decides, or they don't respond, or how do you think that through?
So that's a great question. Obviously, surgery is not a popular option in a lot of patients, and a lot of patients would understandably do everything they could to avoid surgery if possible. And I think in this type of situation, I kind of put them into three different bins. One is, are they truly inoperable? And why are they inoperable? Why are they not fit for surgery? Is it something that looks temporary? Is it just a nutrition problem? They'll get a little bit better. In those patients, I tend to just observe. I tend to try to give more chemo if they can tolerate it, following the phase 3 data for definitive chemoradiation in esophageal cancer. Then there's a second group that they're not going to surgery because they're unresectable. And it might have a T4 tumor, but they're very fit and they're very willing and understand the risks. Now, in those patients, we kind of need a response then. Then I would lean on the stage 4 data, because this would sort of fit into advanced disease. And especially if they have a high CPS, I would be very interested in giving them something like FOLFOX/nivo or some type of chemotherapy plus immunotherapy. Then there's the third group, which is sort of everybody else. And in that group, where it doesn't look like they're ever going to be fit for surgery, what I tend to do is, when they're not fit for surgery, I follow the phase 3 data, give them 2 more cycles of chemotherapy to finish out the consolidation, and then I observe for them, even with a high CPS. I know it's tempting to try to give them something, but you think about, what's our goal here? We have a patient with adenocarcinoma with an intact tumor that you can never remove. In all likelihood, there's a very strong chance that tumor is going to come back. And when it does, if you've been giving them chemotherapy all the way up until that happens, you've sort of, and if that includes immunotherapy, you've burned through that, and now they progress. And it's not based on any data. It's just based on extrapolation from all these different types of studies. And then when they burn through that and they progress on immunotherapy, then what are they eligible for? They're not eligible for any more immunotherapy. And the immunotherapy that they would have been eligible for is based on definitive data in multiple independent cohorts.
So consider this a tasting menu. If you have a lot of questions you want to ask or you're thinking about, it just says you the meals of great interest, but we are going to move on. And Manish, I want you to comment on this next topic we asked the docs about. Again, you can see, general sense of feeling well informed by more than half of the oncologists. First-line therapy of metastatic disease, HER2-negative, and particularly the issue of integrating immunotherapy, and in particular the issue of biomarkers, particularly PD-1, and how it affects your decision. Again, here are some of the papers. If you look in the appendix to the slide set, you'll see lots of slides from these papers, but we really wanted people just to talk a little bit. Manish, can you talk about how you think through first-line therapy metastatic disease, whether you're going to use an IO, how PD-1 affects it, and which IO?
Yeah, no, this is a great question, and things have changed a lot in the last 2 years, so it's important. It's an important topic. So I think that for both gastric and esophageal cancer, it's very clear that immunotherapy plus chemotherapy is an important standard treatment option. Based on Checkmate 649, it was a large study, and we know that FOLFOX plus nivolumab is better than FOLFOX alone, and it was enriched for, the benefit was enriched at CPS 5 or higher. The ASCO, guidelines group performed an analysis of, kind of if there's a way to understand the CPS. And we know, I think all of us agree that the higher the CPS, the more likely to benefit from nivolumab. And so both for NCCN and ASCO, the recommendations, the level 1 evidence is for CPS, PD-L1 CPS 5 or higher, we would recommend it. And we'd leave it up to the physician and the patient for less than 5. In esophageal cancer, pembrolizumab similarly is approved with chemotherapy in CPS 10 or higher. And I think that there are some caveats. So if you're MSI high, you're definitely wanting to consider immunotherapy. I think the other thing that comes up more for squamous cell cancer is the dual agent, immunotherapy without chemotherapy. There's, based on 649, there's data that suggests that that combination is equivalent to chemo plus IO. But, it is an important question, an important landscape. And I think as we get more targets, this will be refined further.
So, Harry, anything you want to add to that? And obviously, the question oncologists want to know is, what do you actually do in your practice, particularly with the PD-1 low patient? How do you discuss it with the patient? And you see this issue throughout oncology, are you a lumper or a splitter? And particularly in the PD-1 studies, this comes up all the time. I'm curious clinically, what's your pearl about how you sit down with a patient who says, I hear all about IOs, why can't I get it?
I think this is a great question that people struggle with. I think if it was just one study, one phase 3 study that suggested the importance of PD-L1 expression in predicting benefit, I would just say it's exploratory, but it's been every positive study. So the way that I do it, and I understand there's issues with the detection antibody and things like that, but for a CPS less than 5, I would just do FOLFOX, because if you looked at, there was an interesting paper came out in JCO where you can actually look at the Kaplan-Meier curves in the CPS 1 through 4. This is not even the 0, but CPS 1 through 4. And this is gastric G-junction adenocarcinomas. And those are completely superimposable Kaplan-Meier curves. And the median survival was exactly the same. Hazard ratio was like 0.95, something like that. So I would say I don't think there's meaningful benefit, but there is a chance for increased toxicity and out-of-pocket cost. Now, if the CPS is 5 or higher, then it's definitely an option. I would say if it's CPS 10 or higher, then definitely I would be recommending immunotherapy plus chemotherapy, and probably for most 5 to 9s.
So, Yelena, I'm curious what your current answer is. I know in the past we've discussed this. I'm curious, again, how you sit down with patients. And also this question from an oncologist in terms of what's your threshold? How do you approach people with prior autoimmune disease, both in the adjuvant and does it change in the metastatic setting? But first, PD-1 low.
Yeah, I think it's this debate is getting outdated because it used to be we didn't have anything better to do for those patients, right? But now we will. So I would not just use it as PD-1 low as in vacuum. Tell me what else do you know about the cancer, right? What is the symptoms like, the disease burden, other comorbidities, but more importantly, in the next 2 to 3 months, hopefully, maybe a little longer, what does the claudin test show? What is the IHC expression? I'm a clinician first and foremost, and I also know how tests work. 1 to 4, if you asked me to bet my lunch on whether or not it's 1 or 2 or 3 or 4, I would say, forget it, And so it's to be so black and white about a gray scale is, I don't feel comfortable with as a clinician if there's nothing else to give to the patient, right? If there's an opportunity to give them other targeted agents in first-line setting, and if the risk is low, until we have claudin inhibitors, I usually start with FOLFOX, nivolumab, or capecitabine, oxaliplatin, pembrolizumab, and then risk stratify for progression based on PD-L1 score, but I don't restrict by PD-L1.
What about the issue of people with prior autoimmune disease? Or what will get you to not do IO?
Oh, of course. So any significant rheum disease where, I basically call the rheumatologist and I ask them. And I can tell you, most of the time the rheumatologist says to me, oh, please just go ahead and treat because, it's a theoretical possibility of something bad happening that they can then deal with versus patient dying of gastric cancer.
So Manish, another question here from the oncologist in terms of PD-L1 testing and the various ways to do that and inter-observer variations.
Yeah, that's a great question. So, the history of this is that, the pembrolizumab and nivolumab and then the others use different antibodies. And there have been sort of correlative studies, and by and large, there is good correlation. I think that when the PD-L1 is high, there's little doubt that that's true, and if it's actually very low, there's little doubt that that's true. But in between, the correlation isn't so great. Just to touch back on the autoimmune disease, so there is actually a trial of immunotherapy as monotherapy in patients who have relative contraindications, so Crohn's disease or autoimmune disease. And in fact, actually, about a third, maybe half the patients can actually get immunotherapy and tolerate it with either escalating or keeping their other disease-modifying kind of autoimmunity drugs in check. So I think that we're learning with the benefit of immunotherapy that we just discussed, there is a chance that we might be able to, the autoimmunity is actually a relative contraindication, not absolute.
So Harry, I want to get your take on another IO that we've seen presented, now published in Lancet Oncology, tislelizumab. And you can see there's a lot of red here in the oncologists because most of them haven't heard very much about it or read the paper that just came out really in the last couple of months. Can you give us a little bit of a primer on this agent? First, also, its mechanism of action. There's some discussion that maybe in some way it's slightly different than other IOs, but more importantly, the clinical data and where you think it's heading.
So a couple of things to clarify about Tisla. It's not FDA approved, so it's not available to us. The data that's coming out, the most updated data suggests that it is a PD-1 inhibitor just like the other ones are. It's not clear that there's something different about it. That's the way I think of it personally. And the emerging data for gastroesophageal cancer looks very promising and positive. I would say it looks very, very similar to the data that we're seeing with Pembro and Nivo, as well as with all the other PD-1 inhibitors that we've been seeing.
So, Yelena, I'm curious here they use a PD-1 assay, a TAP, and they break it down plus 10% or lower. And it's interesting that specifically in the less than 10%, you do see, it looks like a survival benefit. I'm curious, you can maybe have the same drugs, but different trial, different patients going in the trial. There are a lot of potential reasons, but also potentially that the drug is different. Any thoughts about this agent and where it might be heading, assuming we could access it?
Yeah, that's the number one question I get asked in these advisory boards. What do we do with this drug? I think TAP is very similar to CPS. So essentially think about it as CPS 10. In fact, durvalumab studies with AstraZeneca use TAP as well. So it's a known cutoff. So we know that the higher the PD-1 expression is, PD-L1 expression, the better. So it's basically confirmatory data, as Harry said, to what we know about these agents. Do we need another PD-1 inhibitor in the clinic? I think only if you have a exciting partner, because in their pipeline that they could pair it with to augment the response beyond just chemo IO.
Tonight we're going to talk about using durvalumab in the stage 3 in lung cancer, and that's the only one that has the data, so they use it even though they feel like, okay, it's probably the same as Pembro, but they did the trial. The trial is a great trial, and that's what they're using. What about side effect profile, Manish? Again, same as other IOs, any way to differentiate any of these IOs in terms of tolerability profiles?
Yeah, no, I don't know that there are, we can make a decision based on side effect profiles. I think that, each of these large studies were done in although global, but different populations and different enrichment. And I think that background can affect the side effect profile as well. So I think it's hard to make cross-trial comparisons. I think when you compare to the placebo arm, you actually see the similar toxicities at similar rates. I actually think that Tizi is potentially a very good drug. At ASCO, I think last year, maybe a year before, there was a head and neck data that was actually practice changing as well. So it's. I think what we need to know, I think Dr. Janjigian was alluding to this, is that PD-L1 is a poor man's test for how we identify patients who are responding. As monotherapy, CPS 0 patients have had a complete response. So we have to move beyond that, and maybe it's understanding the microenvironment better. We need to understand this better to better kind of select patients and give them the best chance with these agents.
So a couple of questions from oncologists. Harry, kind of related to the issue in general of IOs, including one like Tisley. Everybody wants to know, what about somebody who's had prior IO, maybe they've had an adjuvantly or even in the metastatic setting, secondary therapy with IOs, for example, anti-CTLA-4 combination, or a different, any reason to think Tisla would have a benefit in a patient with a prior Nivo, for example. And then also the interest, and we're starting to see this, of sort of checkpoint inhibitors hitting other targets, LAG3, TIM3. Any thoughts about that?
So there's lots of interesting targets aside from PD-1. So far, the data in gastric cancer, those have not been panning out just yet, but there are interesting ones that are still under investigation, particularly TIGIT. And so we're waiting for those data to read out. Now, with regard to the question of someone who is IO resistant, so frontline therapy, FOLFOX, Nivo, for example, and then they progress, I don't think switching to a different PD-1 inhibitor is going to make a meaningful difference. But there's interesting data from non-small cell lung cancer, especially in the squamous population. In the ICI-resistant group, they progressed on frontline chemo plus IO, and then they were randomized to Pembro plus RAM versus physician choice chemotherapy. And the Pembro ramucirumab group, VEGFR2 inhibitor, which is approved in gastric cancer, led to a greater overall survival benefit. And that was a phase 2 S1800A. And so, that's interesting, is that maybe the use of VEGF inhibition could resensitize these tumors while continuing PD-1 inhibition. I think that'd be an interesting way for investigations to go forward.
So yeah, you could think about somebody who just had an IO and the IO is still on board when you start ramucirumab, would that be of additional benefit? There's a question that came in from the audience, and we actually had a lot of questions from oncologists. I just want to get back to that before we move forward. Yelena, a patient with gastric cancer gets neoadjuvant FLOT. Any situations where you would use post-op IO?
Well, funny you should ask. The press release just came out from Matterhorn, which is FLOT plus minus Durva, and it's good. The press release was positive. So I think soon enough, hopefully, once the survival data reads out and we see the data, we may be able to use therapy perioperatively. The data in melanoma, lung cancer, as you talked about, the Pacific study, all suggests that there may be something important about targeting the tumor while it's sort of strike the iron while it's hot. It's in there, just take care of it. When I use now IO adjuvantly in FLOT is these situations, and that's probably the number one question I get asked. T3N1 tumor, I gave them 4 cycles of FLOT. They had a total gastrectomy. There is 10% response, and there's 17 positive lymph nodes. Effectively, they're stage 4. And with a total gastrectomy, punishing them with more FLOT, they're not tolerating it. So in those cases, I often pivot to FOLFOX Nivo and do more protracted course of chemotherapy, because it's essentially stage 4 disease. It's FOLFOX Nivo now or later when they recur.
So let's talk about HER2-positive gastroesophageal cancer. This has really come on as an important issue in the last few years. Oncologists have heard a lot about it, but we still got a lot of questions about it. Manish, maybe you could just start out talking about first-line therapy in the metastatic setting. Also, we had a question, I'm just going to bring it up now, about the neoadjuvant setting. General oncologists are used to using neoadjuvant chemo HER2 for breast cancer. They don't understand why you're not using it in upper GI cancer. So neoadjuvant therapy, particularly locally advanced, but also first-line therapy, Manish.
Yeah, that's a great question. So I think the most important message is that HER2-positive gastric or gastroesophageal cancer is not the same as HER2-positive breast cancer. The drugs that are active in breast cancer, lapatinib is negative in gastric cancer, pertuzumab is active in breast cancer, negative in the Jacob study in first-line gastric cancer. That doesn't mean that HER2 isn't a validated target. It's just that HER2 is really a subclonal mutation in gastric cancer. So I think that the newer agents like trastuzumab deruxtecan, has proven activity in this disease. That being said, so in the neoadjuvant setting, we do have data. The RTOG study looked at chemoradiation plus minus trastuzumab, and it was stone cold negative. The Petrarca study, which was a neoadjuvant study of FLOT with pertuzumab and trastuzumab, it was suggested that you might have a higher CR rate, but then that study closed early. So at this time, for neoadjuvant HER2-positive disease, we don't have data that we should target HER2, but I wouldn't be surprised if that's going to change over the next 5 or so years. In the first-line metastatic setting for HER2-positive disease, certainly trastuzumab plus chemotherapy is a standard, and then based on Keynote 811, adding pembrolizumab adds a significant improvement in response, and presumably that will translate into survival as well. So I think that's the current standard in first-line metastatic.
So we actually had a case presented, Yelena, of a patient who was HER2 positive, but the PD-1 was negative. And now in your 811 study, I think 85% of those patients were PD-1 positive. So do you still give pembro if they're PD-1 zero?
It's tricky. It's interesting. I can tell you we do. Whether or not it's the right thing to do, the data, the phase 2 data, both from Korea and US, independently, 2 small phase 2 studies suggested that PD-L1 expression is not a factor, but we don't know. I mean, certainly it would be nice to have the PD-L1. I would just confirm tissue content and so forth. But right now, it's approved irrespective of PD-L1 and HER2-positive disease.
So let's talk about, we mentioned T-DXd, and of course we're going to be talking about that tonight with breast cancer, with lung cancer, Monday night, of course, with breast cancer, both HER2 low and HER2 positive in breast cancer. But also, Harry, another interesting bispecific zanidatamab is being looked at in GI cancers. Can you explain what this agent is? This is, I guess, a bispecific hitting 2 parts of the HER2 molecule?
Yeah, it's described as a bispecific antibody that targets 2 independent epitopes on HER2 and can shut down HER2 actions. So, and then there's interesting preliminary data in salvage line settings in multiple tumor types that are HER2 positive, suggesting monotherapy is associated with a response rate in the 30-40% range. And there's data in gastric adenocarcinomas in the frontline setting. What we see right here is chemotherapy plus the zanidatamab, plus I believe it was with tislelizumab as well, and showing an interesting response rate. Now this one, I'm familiar with the data that showed a response rate in the 60% range. So I think it's interesting. It's something that is definitely worth continuing to develop.
So Yelena, I'm curious about second-line therapy. There's been a lot of attention to T-DXd, as we were talking about. Questions from oncologists about what is second-line therapy. Should it be T-DXd? Should it be PAC-RAM? How do you think through second-line therapy, and what do we know about T-DXd in the second line, Yelena?
Yeah, so obviously, the data is very strong in breast, both in HER2 high and HER2 intermediate or low patients. T-DXd has a higher drug-antibody ratio than T-DM1 and has more bystander effect. So it succeeded where many drugs have failed. I mean, there was a 10-year basically dry spell in positive studies in HER2. It works in a third line. We know there's a response and survival benefit in a randomized setting. In second line, it's a single arm study that also shows very similar results. So the FDA approved it irrespective of line. How I think about it is, it's a lot about tolerance of therapy, right? And it can still cause nausea and neutropenia. It's a chemotherapy. And in second line, patients tolerate treatment typically better than in third. So loss of HER2 is an issue for us, and there's disease heterogeneity, outgrowth of HER2-negative clone. So if the tumor is clearly HER2 positive in second line, and if it's feasible for me to biopsy it or do ctDNA, I absolutely prefer to use T-DXd. If I'm not sure if it's HER2 positive or other factors, I still usually use T-DXd. I mean, the FDA recommends that you biopsy if it's feasible. The EMA doesn't, actually. It's now approved in Europe as well. And in patients that are known to be biopsied and they lost HER2 in second line, then I use Taxol-Ram, and then I still use T-DXd in third line.
I mean, I have to point out, and Manish, I'm curious about your thoughts about it, that, and granted it's two different diseases, but just pointing out, because again, the general oncologists are hearing you, they're also hearing the breast cancer people. And breast cancer, if you're HER2 positive, you're HER2 positive in metastatic setting. It doesn't matter if you rebiopsy, you don't see it, they continue to treat people, for example, with trastuzumab, metastatic disease, for life, and yet the oncologists hear you all going, oh, before we start second-line therapy, we get a liquid biopsy, we don't use anti-HER therapy. Any thoughts about that? Is that a difference in culture or data?
No, I think that when we first started using trastuzumab 12 years ago, we actually thought that it would be very similar. It was a validated target for many years in breast cancer, and so we began actually continuing trastuzumab beyond progression, but then there was data that suggested that's not the right thing to do. And we had a bunch of negative studies for lapatinib and for pertuzumab and for TDM1 that's really suggested that it's really not the same. So I think in breast cancer, certainly, if you're HER2 positive, you're HER2 positive. In gastric cancer, you may be HER2 positive initially, but then it's subclonal, so other clones may grow, or you may lose. There may be other mechanisms of resistance. The other way to think of it is that in gastric cancer, HER2 may not be the most important driver of the disease. That's different than in breast cancer. So inhibiting HER2, it's not the same. So drugs that just target HER2, the receptor, may not be enough. And so you may need to have a Trojan horse like trastuzumab deruxtecan, or a bispecific like zanidatamab. There are other strategies may be used, or there's like CAR T therapies that are being developed to target HER2, to use that as a way to home in on the tumor, and then other mechanisms of killing. That may be a better strategy for gastric cancer.
So I want to get Yelena's take on Zani, but before I ask her that, just to come back to T-DXd, Harry, actually, we had a question, I went through it, but let me just read it. 76-year-old man with COPD, HER2 positive, adeno-CA of the GE junction, not on oxygen, but he can walk only a block. Well, is trastuzumab deruxtecan contraindicated? And of course, this comes up all the time. In lung cancer, they maybe don't get so excited because everybody seems like they have cardiovascular problems. Or would you defer it third line? Any thoughts about patients with underlying pulmonary problems?
Right, if I heard you correctly, I think he's on oxygen and can walk about a block. So I would
not on oxygen, but he can walk a block.
Okay. I would not be enthusiastic about T-DXd in that patient because if they do run into pneumonitis issues, it's going to be hard to give that therapy. And we've got other options in second line for HER2-positive disease, including RAM, including FOLFIRI, plus RAM plus paclitaxel. So I would consider those types of agents and not necessarily T-DXd in that situation. Plus there's the issue of the loss of HER2 positivity.
When you do use T-DXd, and this is a big debate in breast cancer, how do you screen for ILD other than educating your patients to let you know if they have any pulmonary symptoms, but particularly about chest imaging and what will get you to stop T-DXd? Will you stop it just if you see radiologic findings grade 1, or you need to see symptoms to, of course you're going to hold it and treat, but to restart?
So, I have not seen this personally, a pneumonitis issue. If it's a grade 1 asymptomatic, I would hold the T-DXd, but if it was a grade 2, meaning it's symptomatic, then the official guideline is to permanently discontinue it. But I think there could be some wiggle room depending on the type of patient. Now, in terms of the monitoring for chest, I do a standard chest CT every 2 months, and so far that's been okay.
Yeah, we're seeing the breast people, even if there's no disease in the chest, they still are imaging as often as the insurance will really allow them to. So getting back to Zani, to me it seems like a really cool agent, but you all know the data better. Any thoughts, Yelena, about where things are heading? Do you think this is going to come into practice?
Me?
Yeah.
It's tough. It's tough. Well, do people use it in breast cancer that much?
Oh, no, I'm talking, no.
Right. Just curious. I mean, that's the thing. It's the issue with Zani is that the regulatory approval in U.S. of Pembro-Traz really made it harder for them to do the study, the definitive study. So the study is ongoing in Europe. And I think if the data looks amazing, but again, it's not being compared to U.S. standard, so it'll be uninterpretable. And it's a shame, because I think our patients now live a long time, and they do need as many options as possible. And using things in second and third line, it's T-DXd alone, is great, but I usually run out of my patients live 5-6 years with HER2-positive disease, so it's disappointing. But right now in first line, I don't see an efficient way forward for this agent in U.S.
So Manish, any thought? Again, another HER2 strategy we're going to talk a lot about on Monday night is the TKI tucatinib, and of course colon cancer also we see tucatinib, trastuzumab. Questions about is tucatinib being looked at in upper GI cancer, but also the issue of HER2-positive brain mets, which of course is where there's a lot of attention to tucatinib in breast cancer. Also the thought of maybe that tucatinib somehow synergizes, upregulates HER2. Any thoughts about whether there's a future in upper GI cancers?
Yeah, so you mentioned something that's very important, the HER2-positive brain mets, and this is actually true across solid tumors, that tucatinib plus trastuzumab actually has really incredible activity in that setting. And actually we have a case report of a cholangiocarcinoma that went to the brain, and their brain was riddled with disease, and then it became like a radiographic complete response. So I think that's one HER2 targeted agent that actually has really unique activity in the brain. Actually, the drug development of this is really, really unique as well. They encourage patients with brain mets to go on trials. We often see these clinical trials where they actually, brain mets is kind of a limiting factor of getting them in, but this is the opposite for this disease, or this drug, this TKI. So it's really, really quite exciting. So there's no doubt in my mind that tucatinib will find a home in solid tumors, not just gastroesophageal cancers.
Yeah, we were doing a program with Zev Weinberg from UCLA about a month ago, and he got tucatinib for a patient who had brain mets, and he was treating the patient upper GI cancer with it. Let's talk a little bit about second-line therapy in HER2-negative disease, Harry. We've already talked about it a little bit, but a couple of things I want to ask you about. First, the issue of FOLFIRI plus ramucirumab. We saw a paper on this. There's been data on this. So how do you choose a partner for ramucirumab? Some of the questions we got from oncologists relate to that question. Do you ever use the taxane without ramucirumab?
So typically I would use RAM plus tax because it showed an overall survival benefit compared to paclitaxel alone. And going back to, I think, Yelena's point earlier, which is a good point, there are patients who progressed on prior perioperative FLOT, and in those patients I might favor FOLFIRI over RAM tax based on the Ramirez data. And aside from RAM tax, FOLFIRI RAM is also a very reasonable option, as is TAS 102.
So I want to also talk about Zolbetuximab. We already have referred to it. Yelena brought up a situation that, again, we got a lot of questions about in terms of a patient with a high claudin and low PD-1. And you can see there's a lot of questions oncologists have about Zolbetuximab. We saw, of course, the Spotlight trial, phase 3 study in the first-line setting. We're waiting to see whether it's approved. Harry, can you talk a little bit about the mechanism of action of Zolbetuximab, and then a little bit about your take on the Spotlight study?
Sure. I think these are fantastic studies, and they're definitely positive, hit every endpoint except for the response rate, so improved overall survival, improved PFS. And claudin 18.2 is a tight junction protein. The way it's different from all of these other targets like HER2, FGFR2, is that it doesn't have downstream signaling as far as we know, but it serves mostly as sort of a signal for the drug to reach that area and then to deliver the different payloads. And so in the claudin-positive group, these were clearly positive data. Now, to clarify, this is not approved yet, but we're anticipating that it would be approved. And if it is approved, I think at that point we're going to have a lot of options, and it's going to be just how do you select through that? And for me, it would depend a lot on biomarker status and other clinical factors.
So just for fun, Zolbe high, claudin high, PD-1 high. Can you give them both?
As far as we know, we don't know that we can. It's probably safe, but there's no activity when it's just the two antibodies. When they're combined with chemotherapy, there's very, very limited data. So if it's, let's say, a CPS 10 or higher, I would favor IO plus chemotherapy because the hazard ratio in that group is like 0.66 with, let's say, nivolumab. And if it's CPS less than 5 and claudin positive, I would give Zolbe plus chemotherapy. And it's that in-between group of the CPS 5 to 9, and it's not a common group, but if that comes up, there's some interesting subgroup analysis that was consistent between Spotlight and GLOW, indicating that there was a strong benefit in the gastric cancer subgroup as opposed to the GE junction, and it was shown in both studies. So if they're gastric, I would favor Zolbetuximab. If they had significant autoimmune disease that I didn't think that they could get beyond, because I think there's interesting data of low-dose nivolumab, even people with autoimmune disease, then I would favor nivolumab.
Low-dose nivolumab in people with autoimmune disease. That sounds interesting. Manish?
Yeah, so I think this data will be coming out more and more, but I think that the primary claudin 18.2 positive patients are, a significant proportion of them will be CPS less than 5. So, in both GLOW and Spotlight, that rate of being CPS less than 5 was around 80% or so, 80 or 85%. So it may be kind of, we're going to be in a space where you're going to need to do mismatch repair, claudin 18.2, the CPS as well, and you'll have to, and maybe FGFR2, you have to tailor your therapy based on what target is the most dominant, and then go from there. I think that the other thing that I would mention is that just to what Harry's point is that this target is actually a normal target on the gastric mucosa, and as the cancers develop, it actually becomes exposed, and so kind of an on-target effect is the main toxicity that you see, the nausea and the vomiting. It's not that it doesn't, we don't have any data that this is associated with a high rate of response, but it's something that is to be expected. And after the first cycle, you can really tolerate the drug really quite well. So that's a key message, is to stick with the drug if possible.
So, Yelena, any comments on the nausea that you see? Harry was telling me that you actually can see this during the infusion. It's, I guess, a direct effect on the gastric mucosa. What do you see? Is it preventable?
We do see quite a bit of nausea, and it's varied. Again, anecdotally, what I see is the higher the claudin expression, the higher is the nausea, which is kind of interesting because, when I used to treat lung cancer with the GFR mutations, right, if you have a lot of rash, you know that you may do better with erlotinib. It's quite a bit, and if you already have peritoneal disease, it's usually the younger women with high claudin and a lot of peritoneal disease that suffer the most, and it's not that easy to get them through it. A lot of times you give them Adjuvant during the infusion. That's what I have had to do, and slow the infusion, split the infusion.
Do you see the tachyphylaxis that Manish was just referring to, that second and third cycle is better, or not necessarily?
maybe they just get better, start, I think some of it is underreporting also. Grade 2 nausea, it can be devastating, but not, severe. I think they just learn to sort of deal with it. They are on olanzapine. Using olanzapine does help. Steroids, basically they need to be on steroids for 3 days after. So Dex day 1 through 3. Splitting the infusion, it's a project.
So yeah, I've been calling upper GI cancers the new breast cancer, and the ER and HER2 that you need for any breast cancer patient. I'm wondering if PD-1 and claudin 18 is going to become the new ER and HER2, that any kind you present a case, you're going to need to say what it is. Do you want to tell us what you're thinking right now, Yelena, in terms of how you're going to look at the claudin level, the PD-1 level, and figure out which of these agents, and the clinical situation, figure out which route to go?
Yeah, I think as I have this mic and podium, I think what's sobering to me, and when I talk to the market researchers and so forth, it looks like up to a third of patients, still first-line patients in adenocarcinoma in the United States, never get biomarker tested, which makes me want to drop everything and go into marketing or something, because all the work and advancements we do, it only makes sense if it actually gets to the folks that are getting treated in the community. So that's important. But yeah, absolutely. Critical biomarkers are MMR testing, and you have to do that in perioperative setting, because you can harm your patients if you don't know their MSI, if you give them FLOT. And of course, HER2, PD-L1, and now claudin. What's going to be next? Probably FGFR2b overexpression, which is nice because it's all immunohistochemistry test. It comes back quickly. It's not IHC comes back in 3 to 5 days, as opposed to waiting weeks for next generation sequencing.
And are you anticipating you're going to have to choose between bemarituzumab and Zolbetuximab?
I hope so. I hope we've been on a roll. Whenever I show the trajectory of drug development in this disease, there's a decade and a half of negative studies, and now it's been nice to see all these positive studies. So I'm hopeful. We'll have to see.
And your comment about the lack of biomarker testing, we hear this in every cancer. People go out, they try to get data, they see that things that they think are standard of care aren't getting done, and they assume that it's the oncologist who doesn't know. But there's another issue, which is access. Socioeconomic disparities that we know exist in terms of getting things paid for. Yeah. And so we see that every day. Incidentally, am I right? Because this again was a question of, I don't know if we put it up here or not, but a lot of people are, the testing question. So Harry, you don't get this on NGS, right, claudin? You have to order it separately?
That's correct. My guess is that all of the molecular testing vendors are actively developing claudin, and they're already have added PD-L1. So I would be expecting they're going to have something like that available with their NGS.
Another question here about the Spotlight trial, Manish. This doc was questioning why you didn't see a difference in response rate. Survival is super cool that they saw that already, but what about response rate? Any thoughts on that?
Yeah, so this is a phenomenon we saw both in Spotlight and GLOW. So altogether 1,000 patients. And I think numerically there was a slight increase in response, like 53 versus 48 or something like that, but not significant, statistically significant. I think that it may be related to partly the mechanism of action. Remember, there's no downstream signaling of claudin 18.2, as Harry mentioned. It may just be kind of a way to activate an immune response once the antibody binds. That's the intent of it as well, anyway. So it may be that we don't expect to see shrinkage of the tumors per se, but we do expect growth inhibition. And there was actually a recent JCO article about particularly with targeted therapies and also immunotherapy, the lack of correlation between response and survival. These are not cytotoxic drugs. These are drugs that work by other mechanisms of action. I think for me, the thing that I would take home is that in 2 randomized studies, compared to chemotherapy alone, the addition of zolbetuximab improved survival by roughly a hazard ratio of 0.75 to 0.7.
Yeah, that's a pretty easy variable to measure too. You can't argue with survival, whereas progression-free survival can be a little bit debatable. So, Harry, I mentioned the fact that the oncologists are all interested in circulating DNA. It was really revolutionized the approach to colorectal cancer. So they're looking to see where else they can use it. We're going to talk about it tonight, and almost every solid tumor. What do we know about cell-free DNA and upper GI cancers? Harry, do you see that coming into clinical practice?
Yeah, I think this is very promising, ctDNA, and I am personally using it, ctDNA, in my practice. I'm not sure if it's really helping the patient, but it's a very helpful reassurance marker, because a lot of times we do CEA and those kinds of markers, which have maybe even less data. And but there's patients where, like, let's say they're MSI, and we're thinking about surgery, but they're kind of borderline for surgery, and but maybe they will be ready for surgery, and then getting a ctDNA can sometimes help with that, mostly in terms of reassurance, because if it's 0, 0, 0, then it sort of gives us reassurance that we don't need to go ahead with surgery. Now, whether that's ultimately the best thing and what would get proven in clinical trials, I don't know, but that's how I'm using it.
So, Yelena, I'm curious about your thoughts, whether you use it. One of the scenarios that we mentioned, MSI high, that we see people using it is people having long responses to IOs, and you don't know whether to stop or not. Of course, the problem is, you get the assay, but you don't know what to do. I mean, if it's positive, it sort of tells you something. If it's negative, I'm not sure what it means if you don't have data. So are you using it? And what about these people who have long responses to IO and they want to keep therapy going? Would you try it there?
Yeah, you hit the nail on the head. That's exactly. Most of the time, when ctDNA used in postoperative setting, I would call it morbid curiosity, because if you have ctDNA positive after FLOT, what are you going to tell that patient? So absolutely, I would never do that. I do use it selectively, either obviously in a trial or in metastatic setting, but only in patients who were tested at baseline, so day 0. Don't start checking at midway and feel reassured by a negative test, because you never know if the patient was ever a secretor, right? The ctDNA was maybe not circulating. And I mostly use it in the example that you brought up as a MSI patients. In stage 4 disease, my patients, because they tolerate IO alone so well, they're incredibly hesitant to stop treatment after 2 years. So I use it as a reassurance and a affirmation that it's okay for you to take a treatment break.
So final thing we asked these oncologists was impediments to delivering high quality care in their practice. And Harry, I'm curious, one of the most common was these people are really sick, particularly when they have metastatic disease, particularly when you get to second line therapy. They deteriorate very rapidly. It's hard to get them on trials, they're so sick. Molecular testing, sometimes in the community, doesn't come back as quickly as it does for you all. Any comments on this issue, Harry?
Oh my gosh, I agree with the whole list. I mean, this is just a small tip of the iceberg. The nutritional issues, the performance status, everything that you're talking about, the out-of-pocket costs. There's lots of issues in terms of barriers.
Manish, any thoughts?
Yeah, so I think that the biggest, these are all real issues, and I think the biggest challenge is, and this is I think how all of us practice, is that we really try to map out what we need to do, because you don't have much of a luxury of sort of the patient's progressing, now let's figure out what to do. You have to actually anticipate that 3 months, 6 months ahead of time. So we get the biomarkers early, so we have them ready. And at the very, very, very first sign of progression, we don't wait the other month to get a CAT scan. We get on the horn and get the authorization, get a scan, demonstrate progression, and move to the next thing. Because this is reality. These are very aggressive diseases. They're morbid, and if we don't act early, then most patients don't get second, third, fourth line therapy, and that's partly because you just need to anticipate what to do next.
So final comment from Yelena, again, getting back to this issue of supportive care. It's so exciting to have all these new agents, but then we got to try to help these patients in terms of quality of life. I'm curious how your team at Memorial approaches this, how you involve other professionals, particularly in terms of nutritional support.
Absolutely. With all of these fancy toys and drugs we use, the number one thing that helps the patients is specialized nursing care and management of their symptoms. Data shows that. So close follow-up, phone calls, being able to fit them into hydration, hydrate them at home if needed, always been important. And, I have a team of nurses, nurse practitioners, fellows at my disposal, which is certainly a luxury, and that's not the case for some of our doctors in the community. And so that's the challenge for the patients. And I think that's the reason why we need to really cluster care for this disease that's relatively rare, and as Manish was saying, it goes from 0 to 100 in terms of deterioration in centers that are high volume and that have the support. And that's part of the reason why I'm nervous about opening some of these trials internationally, because, as these regimens are piled up on top of each other, I know I'll be able to rescue the patient if there's an adverse event. I'm not so sure if other centers will be able to.
Very great point there. So I want to thank the faculty tonight in this room, 6:30. Please come here. It's going to be very, very different. We're going to talk about lung cancer, but in a way that's very, very unique. Thanks so much to the faculty. Thank you for attending. Have a great day.
Thank you. Thanks for coming.